first presentation will be, is normal saline the best fluid for resuscitation, as our ICU ancestors had believed, by Dr. Karol Kamel.
Thank you, Dr. Fried. Hi, I'm Karol. So yeah, let's just jump right in. So why does this topic even matter? I think we all know how important IV resuscitation fluids are for critical care patients. And then not only that, like obviously we know the 30 cc's per kilogram for all patients who come in with septic shock, but just throughout the hospital stay, we know how crucial it is to resuscitate patients with fluids. And for decades, normal saline has been kind of the mainstream fluid resuscitation. However, new evidence coming out just in this decade has been challenging that belief. So let's jump right in. So we surveyed a group of cottage residents, and survey said about 27.8% when asked, without looking anything up, do you know why we prefer isolite over normal saline for fluid resuscitation and septic shock? 27.8% said, yes, duh, normal saline is bad for the body and soul, and that's proven by research. 22.2% said, not sure, I know NS is not great, but I'm not sure why. And then we had other write-in answers kind of on the topic of something about less acidosis with isolite. The good news is 0% of people picked this option, which it's just like what people told me to do, so I do. So that's great. We're at least not doing things just because we're told. We're thinking about it a little bit. So delving into the history of how did we get here. Back in the 1800s, in 1830s, this cholera epidemic came about, and Dr. William Brooke, I'm supposed to make an SNL joke and say Dr. O. Shag Hennessy, proposed IV fluids to replace electrolytes. This was the first ever time, a year later, that Dr. Latta administered the first isolite solution, IV solution, but it was actually hypotonic compared to plasma. Later on, Dr. Hartog Hamburger developed a solution that he thought was actually mimicking plasma, but in real world, which we'll go into the next slide, it actually was what we know as normal saline, which does not mimic plasma. And then in 1880s, Dr. Sidney Ringer, as we all know, who developed lactate Ringer, did develop a more physiological alternative that is much closer to plasma than normal saline. And then jumping into the 1900s, World War I and II came about. Normal saline was cheap, quick, easy to store. You could just put it on a shelf. It was mass-produced, so it was the mainstream fluid resuscitation for the war, and thus after that, it was the fluid resuscitation that the majority of hospitals used. Now coming a little bit closer to our day and age, 1980s to 2000s, was the era of unquestioned NSU. Some research was starting to come out that maybe there's some bad side effects to it, but still it was the mainstream solution, and now 2010 to the present. So from 2018 to up to this year, there's now research, study after study, multiple RCTs across multiple ICUs coming out with all these studies comparing NS to balanced crystalloids. So just to jump a little bit into the composition, we won't harp on this slide too much, but if you just look here and you look at LR, plasmalite, and isolite, much closer composition to plasma. Maybe LR has a little bit low sodium than plasma and isolite, but if you look at the normal saline, it is drastically different, right? It's got a ton more sodium, it's got a ton more chloride, it's hypertonic, and it's cheap, but it's just very, very different. So some proposed problems that people have hypothesized over the years about why it's bad to use normal saline. The first one being hyperchloremic metabolic acidosis. So basically normal saline contains 154 milliequivalents per liter of chloride, far, far more than plasma. So this increased hyperchloremic levels can lead our kidneys to try to dump that chloride, and with it they dump the bicarb, creating this acidotic state. So as our pH falls, we all know kind of that effect of the Bohr's curve being shifted to the right in your body in an acidotic state. Your oxygen isn't hanging on to hemoglobin as well. Your cardiac output is going down. It's just, we kind of all know the risks of being in an acidotic state, hypotension, increasing vasopressor needs secondary to that. Of course, I had to include a Grey's Anatomy joke in there. So another proposed problem was the increased risk of acute kidney injury. So again, in the same line of this hyperchloremic state, the kidney is just kind of like in a wonky state. It's got all this chloride around that causes a couple of things to happen. One of them being it triggers this afferent arterial vasoconstriction in a couple of mechanisms. So one of them is chloride inhibits nitric oxide production, and that's a key vasodilator. Another thing is it stimulates endothelin-1, which is a potent vasoconstrictor, again causing impaired renal perfusion. And additionally, this hyperchloremic metabolic acidotic state from normal saline worsens these effects by activating the RAS system, which increases renal stress. So kind of turns this bean into a not very happy bean. So lastly, there was potential for increased mortality, and this was talked about, and it hadn't been definitively proven. A lot of studies have suggested that it may be associated with a higher mortality rate, but it had never been proven, or is it? So we'll jump right in the next few slides. I'm going to talk about a lot of studies, so just bear with me. I know this isn't the most fun or entertaining, but I put in some cartoons to hopefully make it more fun. So the first trial was a SMART trial, and this was 2018. This was the biggest trial on this subject of the time. They took 15,000 ICU patients from different ICUs, medical, surgical, neurocrit, and trauma, and they evaluated a primary outcome of the MAKE-30 composite, which was death, new dialysis requirement, or persistent renal dysfunction. So with the secondary outcomes being like length of stay, hospital mortality, and then this study had a couple of sepsis subgroups as well within it. So basically, the findings for anyone interested in percentages, balanced crystalloids reduced MAKE-30 events from 14.3% with balanced crystalloids versus 15.4% with the normal saline group. The normal saline group had a much lower serum potassium level and higher rates of renal dysfunction. It was approximated that new dialysis requirements were 2.5% in the balanced crystalloids versus 2.9% in the normal saline group. And then a sepsis subgroup in this study did show a statistical significance in reduced mortality or a mortality benefit with balanced crystalloids. And then just because in the next couple of slides I'm going to be using kind of a lot of these other balanced crystalloids interchangeably, whether it mean LR or normal sol or isolate. This SMART trial did a bonus trial where it compared LR versus normal sol. They basically randomized about 1,000 patients to receive one or the other as a primary fluid resuscitation, with a primary outcome of plasma bicarb concentrations in the first week and a secondary outcome of renal replacement therapy, as well as a couple of the MAKE-30 criteria we talked about in the last slide. And long story short, no significant difference was found between these solutions. They just talked about the biggest benefit being the cost. So just going on into another trial, the SALT-ED trial. This one was not an ICU trial. This was actually just thousands of emergency department patients that did not end up requiring ICU level care. And same thing, NS versus balanced crystalloids. This one's primary outcome was hospital-free days at 28, with the secondary outcome being the MAKE-30. And this study found that NS was associated with a higher AKI incidence, 5.6% versus 4.7% with a p-value of 0.01. NS was also associated with lower potassium levels, but not severe hypokalemia. Again, this was just in the ED level, so it wasn't like they were getting fluids all throughout their hospital stay. And balanced crystalloids did increase hospital-free days at 28 days, but no significance in overall mortality in this study. The next two studies we're going to talk about are quite similar, so I'm going to kind of group them into one. It's this BASICS trial and this PLUS trial, and they were double-blinded RCTs, thousands of patients getting either balanced crystalloids or normal saline, and then they studied subgroups in them with TBIs as well. And the biggest findings of these studies was there was no statistical difference in 90-day mortality found in these studies. The sepsis subgroup had worse renal outcomes with normal saline. Normal saline did also lead to transient decreases in potassium, some patients requiring repletion. And then there was no difference in AKI rates overall in this study, but normal saline did have more severe renal dysfunction cases found. So we're going to use this word of trend a lot. They showed that patients trended towards worse outcomes with normal saline. And then in the TBI subgroups of both of these studies, they did found that even though there was no statistical significance in mortality, but there was, or neurological outcomes, there was a trend towards TBI patients doing worse with balanced electrolytes than normal saline. And we'll touch on that a little bit in the end. So then, I know this slide looks overwhelming and we won't break it down too much, but these are just the 3 most recent meta-analysis studies within the last 2 years. So these 3 studies basically took a bunch of RCTs and combined them and looked at a primary outcome primarily of 90-day mortality and AKIs. So the biggest findings in these ones, so none of them actually found a statistical significance in decreased mortality, but the Hammond et al. Study did find a higher risk of AKI with normal saline. And then, again, they also, all these 3 studies looked at the TBI subgroups, which showed similar studies to what we found, or we talked about last. So let's just dive in for a quick minute about this statistical significance. I know when we all are reading a paper and we see that there's no statistical significance, our mind kind of automatically jumps to the results are not relevant, right? Like, that's kind of not what we're taught, but at least what we tend to look for is there a statistical significance in these studies? So the biggest thing with these past couple of studies is they were meta-analyses. So with meta-analyses, you're taking thousands of different variations of these studies. Already within the RCTs, it's across multiple ICUs, and now you take it on a larger scale. You're creating a lot of room for variability, right? You're creating a lot of room for co-founders that aren't like thought about during the studies. And then this was the coolest thing, was this study, Hammond et al. Took the meta-analyses and they reran the data. Instead of using an absolute p-value, they used the Bayesian analysis model, which is basically a model that allows researchers to integrate results from multiple studies and accounts for variability, predictability, prior outcomes, and confounders. And when they did this, they actually showed statistical significance in both AKIs. They also showed that with balanced crystalloids versus NS, balanced crystalloids had approximately a 9% mortality reduction to a possibly 1% increase. But even with that, it was more towards a much bigger percentage of mortality. And then they also found that there was an increased risk of high-risk patients, especially with AKI and length of stay when given normal saline. And then in this chart here, you can see that they did them like quartiles. So basically, the more right quartiles you go, you're getting more fluids as you're staying in the hospital. And with this, they found that there was a significant statistical significance in the trend going down in mortality with patients receiving balanced crystalloids, while there was no statistical significance in the trend of mortality going down with normal saline. So last study, I promise, guys. So in this study, which actually came out in 2025, Galbanager latest sepsis study was a secondary analysis study that looked at this parent trial, this Clover's trial that studied multiple things, and they just focused on the fluid resuscitation part of the study of NS versus balanced crystalloids. And the biggest, basically, the biggest thing that this study found was that the LR group exhibited a statistically significant reduction in mortality before discharge home by day 90 compared to the NS group. The patients in the lactated ringers group did have a significantly more hospital-free days within the first 28 days post hospitalization, or rather post when they started the trial, which is when they gave them fluids. And then normal saline did show or was associated with more cases of hyperchloremia and metabolic acidosis. So for anyone who's interested in numbers, these are all the numbers, but I won't harp on them. And then just to mention limitations, obviously with a secondary analysis study, there's going to be limitations, right? There's going to be, you can't conclude causality in a secondary analysis paper. then there's always going to be variations in between fluid administrations. There can always be a chance that patients got mixed, some normal saline, some LR, or vice versa, and then there's always going to be unmeasured confounders. So getting into the bottom line, so for sepsis and septic shock patients, isolate or LR should be the preferred resuscitation fluid. And then for general ICU resuscitation, you should always choose a balanced crystalloid. These are very high-risk patients. Their body's physiology is already struggling a lot. So introducing a fluid that is going to kind of confuse the kidneys more and create a less physiological state for them is just going to make healing harder. And then for neurocritical patients, TBI and stroke, these might be the only cases where you might consider NS to prevent cerebral edema. But these are patients that, one, we're not really treating very often, and two, they're oftentimes getting 3% hypertonic saline. So it makes sense that normal saline, which does have more sodium than balanced crystalloids, would help cerebral edema, or at least show a trend in it. And so I think the evidence is there that trending towards a physiological solution may be better than normal saline. And then these are the resources. And this is just the last joke I got.
Thanks. Anybody have any comments or questions for Dr. Kamel? I think certainly the trend in this hospital has been to go to balanced salt solutions for a number of years now. And I think, the data, although the numbers are really small, and not the numbers in the terms of the studies, but the percentage differences may be very small, but given the number of people that are resuscitated per year, it really, even a small change in mortality or AKI or whatever can lead to a really large number of extra people surviving. So, yes, Dr. Archimala.
I think in a lot of those studies, and Karol can correct me if I'm wrong, the average amount of fluid that most patients got was right about a liter. So imagine how different that would look in your patients that are getting 4, 5, 6 liters of fluid when they come in for resuscitation.
Yeah, so could everybody hear that? I agree. I think some of them had more than a liter, but it wasn't like 5, 6, 7, 8 liters in a short period of time, which is often what we do for a lot of the ICU patients that need fluid resuscitation. And the last study, she didn't show it, but one of the findings or one of the interpretations of that study was that a lot of these studies had mixed the patients that were enrolled after they had already been partially resuscitated in the ER or out in the field. So they had, even the patients that were randomized to the balanced salt study group got a significant amount of saline in other places before they were randomized. So there was a lot of contamination in a lot of the studies. And also, one of the other findings was that the earlier and more aggressive the resuscitation, the better the patients did. And if you started with a balanced salt solution rather than saline, they seemed to do better. So, okay. All right, well, it's time to vote. Is it a myth? Normal saline is the preferred resuscitation fluid for almost all critically ill patients. Said almost because of the traumatic brain injury subgroup, which seemed to have maybe a worse mortality. How many people think that this is true? How many thinks it's plausible? How many think this is busted? Karol, you got it. All right, we're busted.